Alright. If you're not already so, go ahead and mute because there's some echo. For those that are not muted. And we're going to go ahead and get started. So, for we're in 1350, we're in Module 5, peripheral vascular disease. Yes, Asa.
I was just making sure you could see me online.
Yes, I see you.
I'm done.
Okay, let's see here. Also, as a reminder, after your ACLS course on Tuesday and Wednesday, hey, Mama, can you mute your computer because it's giving an echo? Thank you. So there's no class, of course, on Thursday and Friday because of the holiday, and we'll meet again on Monday. The following Monday is going to be a review for 1340 and 1350. So we're not going to do any review stuff today. We're just going to talk about 1350. And it's going to be peripheral vascular interventions. So with that said, your learning objectives for today are going to be to familiarize yourself with peripheral vascular anatomy, the interventional tools, and let me see, interventional tools and procedures, and also how we use digital subtraction angiography, so DSA. Okay. So we want you to kind of focus on that. The reading for this module is going to come from chapter 15, not chapter 11. Not chapter 11. So I'm changing that right now. So chapter 15 in your current interventional book. And then the other supplemental stuff I put in the module is what we're going to focus on. But now, going on to the PowerPoint. So diagnostic testing, upper extremity interventions, abdominal interventions, lower extremity interventions. Oh, sorry. So usually when we're talking anything peripheral vascular, we're talking about everything and anything outside of the heart. So we're talking upper extremities, we're talking the arms, we're talking the neck, and anything cerebral, even though cerebral is its own category. But anytime you're doing anything on the great vessels, the aortic arch, the subclavian, moving down from the armpit down to the hands, you have your axillaries, your brachiocephalics, your brachial, all the way down to the radial and fingertips. Those are all upper extremity. A lot of times when we're doing upper extremity, if it's arterial, we're looking for a blockage or an issue, like we do with the heart. If it's venous, then we're looking for a blockage of a different nature, and we're going to talk about that a little bit more. But a lot of times, if it's upper extremity, a lot of the times we're looking at dialysis grafts, AV fistulas, things like that. So just know when we're talking about upper extremity, we're talking about the upper body, your upper appendages, your upper extremities, okay? Your arms, your neck, your head, whatever. And then we have abdominal. Abdominal is going to encompass the abdominal aorta, thoracic aorta, your renals, your mesenterics, your splenics, every vessel that's going to feed an organ or organ system is what we're usually talking about. We're talking about abdominal interventions. And that usually goes down to the pelvic area where the aorta is going to split into the iliac arteries. And then after the iliac arteries, we start getting into lower extremities. We start getting into the legs. Sometimes the external iliacs into the femorals. We usually include the external iliacs in the lower extremities, but when we're talking common iliac, because it's up in the lower torso, where the reproductive organs are, we usually consider that to be a part of the abdominal. Even though it's bifurcating and going down towards the legs, we still kind of consider that an abdominal area. So when we're talking about disease in the periphery, we have PAD and PVD. PAD is peripheral arterial disease. Okay? Again, that's leaning towards the arterial side. So we're looking at arteries, we're looking at oxygenated blood, and that's what's feeding the muscles. So it's taking the oxygenated blood to the muscles in the legs, to the organs in the torso, and then you have PVD, peripheral venous disease, which is sometimes PVD is also used as an umbrella term for peripheral vascular disease. And when we're talking about peripheral vascular disease, they're kind of keeping everything kind of looped in together. So when they're talking about peripheral vascular disease, they're usually including arterial and venous. But for the sake of this conversation, I want to split them up because they behave differently. Your peripheral arterial disease is going to present and behave differently than your peripheral venous disease because both systems have different purposes. Okay? So if a patient were to come in with peripheral artery disease, then we're talking about arterial insufficiency, and this is going to be due to blockages in the arteries. If there's any arterial sclerosis where we have hardening of the arteries, and so we have lost, or the patient has lost the ability to, for the arteries to dilate, constrict properly, and that can lead to ischemic issues. Usually if a patient has arterial insufficiency or peripheral arterial disease, they're going to present with muscle cramping. They're going to present with pain in the legs, in the hips, in the arms, and this is going to worsen with activity. So in the legs, we call that claudication. So you're getting anginal type symptoms, but not the heart. You're feeling it in the legs. And so if the patient is out, they're walking, they're doing different activities, and then after a certain period of time, they start to experience this cramping, the pains, the achiness, and whatever. And when they rest, the pain subsides. And then if they go back to their activity, the pain is going to come back. It's kind of like stable angina. It's going to behave in the same way. And it's very dependent upon activity. So in the upper extremities, it's going to, let's say somebody has a blockage in their subclavian. Okay? And what that's going to do is that's going to present with pain and cramping and discomfort if it's a left subclavian blockage in the left hand. If it is a right subclavian, then it's going to present in the right hand. Let's say somebody is working out, they're lifting weights, or they work with their arms a lot. After a certain period of time, after a certain amount of activity, that arm, whichever side is affected, has a disease, is going to cramp. It's going to become very painful, and they will rest a little bit. And again, it's going to help. The resting period is going to take down the myocardial oxygen demand, so the blood flow is going to decrease. So we don't have to worry about the vessel dilating. So if you take the increased volume out of the equation, then all that blood volume isn't trying to squeeze through a narrow blood vessel, so we don't wind up with ischemia because those muscles aren't getting decreased blood flow during periods of rest. So if you apply the same way of thinking with angina in the heart to the peripheries, then you understand claudication. Moving over to the peripheral venous disease or venous insufficiency. This happens when there's inadequate return of venous blood from the legs back up to the heart. Remember, the whole purpose of the venous system is to have a place, to have a network for that deoxygenated blood to make its way back to the heart, to get to the lungs, to get reoxygenated so we can continue to feed the muscles, tissues, and organs. So in situations where we have venous insufficiency, maybe the veins have dilated. And if you look at the image, you see in the veins we have valves, right? Now these are one-way valves. They're supposed to be one-way valves, where they only open in the direction of blood flow to the heart. But when the veins get dilated or damaged over time, you see these valves become damaged. And when they become damaged, it impedes the blood flow going north to the heart. You're going to have periods where you see your blood is kind of swirling around within the veins, which is going to increase the volume in these little segments. And with increased volume comes increased pressure, and the body does what it does to cope with this increased volume. It's going to stretch, it's going to remodel. So when you have venous dilation like that and the swirling of blood in a low pressure system, what can happen over time is clot can form. And this is how DVTs happen. Deep venous thrombosis. This is how these happen. And DVTs are very dangerous because eventually that clot is going to become loose. And when the clot becomes loose, it's going to migrate north and enter to the heart and the lungs and cause issues like pulmonary embolism, heart attacks, strokes, things like that. And we don't want that. So, the patient presentation for peripheral vascular disease is different than arterial disease because the issue isn't, with venous disease, the issue of concern isn't lack of perfusion of lack of perfusion of blood into the muscle and tissues and organs. This is a lack of venous return to the heart. So the patient is going to complain of very fatigued, tired, heavy, achy, cramping legs because we have volume overload in the legs. It's holding on to excess volume there in veins in the lower extremities. Pain is going to worsen when they stand, and it's going to improve with leg elevation or with the use of compression devices, compression socks, hose. Those you've seen those things, those compression thingies, those wraps that you can put around your legs, and it will apply pressure, kind of counter pulsation pressure on the legs. Usually if somebody is in the hospital for a long period of time and they're on bed rest, they will put that kind of counter pulsation compression leg wraps on the patient. So it will aid in venous circulation going from the lower extremities up to the head. So the whole idea is to kind of get that blood moving. But if the veins are distended and they're damaged, then you lose that natural ability to kind of have that blood going back towards the head. Now, movement, doing calf raises, walking, stretching, things like that are going to cause the muscles to kind of squeeze down on the veins. And that's going to help aid blood flow back to the heart. Okay? So with peripheral arterial disease, the issue is ischemia. So we got cramping, leg pain, we have ischemic issues that usually subside with rest. With venous insufficiency, we have a hypervolemic issue in the lower extremities. Okay? And that's only going to really be relieved by elevating the legs and by just gravity. It's going to help drive that blood towards the head. Or with the compression devices, it will help push and propel that blood towards the head. Okay? Any questions on the difference between PAD and PVD? Alright, moving on. So here's a nice little graphic that kind of gives you the difference between the different symptoms of PAD. So with PAD, remember that is a lack of blood flow. Okay, we're worried about ischemic events. So with PAD, the skin may be pale or have a bluish color. Okay, we got a lack of oxygenated blood flow reaching the muscles, so it's not going to have that well-perfused, full of color look to them. The patient is usually going to have weak or absent pulses in the feet. Now, we know that if we're doing a cath in the cath lab, even if we're going radial, we're still going to check the pulses in the feet, right? We're going to check your posterior tibialis, which is over here behind the inside of the ankle, and the dorsalis pedis, which is right here on top of the foot. If we find that the patient has weak or absent pulses just by palpating them, our next step would be another device to see if it's just so weak that we can't feel it, but maybe we can hear it. So we will use a Doppler probe. And with the Doppler probe and conduction jelly, we can hear the blood flow if there's adequate or if there's blood flow going to the feet. If we can't hear the blood flow via a Doppler or Doppler probe, then we know that there is significant peripheral arterial disease in that leg. And what you'll probably find is the foot in that lower leg is going to be really pale. It's going to look ischemic. There may even be some gangrene, some necrosis on the toes or somewhere on the feet if you don't have blood flow to the foot. Another symptom would be the shiny skin, really, really shiny skin, shiny tight skin, and loss of hair on the legs. If you think about it, hair, even the hair on our head, needs adequate perfusion. We need oxygenated blood flow in our scalp and the tissues of our head to help blood flow grow. And that's why you see a lot of these, beauticians and hairstylists, they promote and do scalp massages because it's encouraging increased blood flow to that area. With increased blood flow, the hair follicles get the nutrients they need to grow. Okay, so if you have an issue with ischemia in the legs, the hair's not going to grow like anything else. That requires oxygenation and all the nutrients that are in our blood. Also, you may see that there are some sores or wounds on the toes, the foot, that just aren't healing. We see this a lot in diabetic patients. Okay, but diabetic patients have really bad and kind of aggressive peripheral arterial disease. Okay, so if a person comes in and they're like, I cut my foot, I kicked something and I cut my foot and it's just not healing. And I've been bandaging this wound cut forever and it's just not healing. Well, it may not be healing because the vessels in the leg are narrow and diseased and we can't get blood to this area. And when we're talking about injuries like cuts and gashes and scrapes and all that stuff, we need the platelets. We need all those different things in the blood that are going to help aid clotting, which are going to help aid, healing, to grow a scab and to heal the tissues underneath. And if there's no blood flow, then that's not going to happen. So a lot of times when we get our patients that come in outside of the claudication, outside of the decrease or absence of pulses, outside of the pale skin or the loss of hair on the legs or whatever, we're going to find sores that aren't healing properly. Okay, and usually that's what finally brings them in, because a patient, we know with heart disease, these patients will sit here and they will endure pain. They will endure chest pain and either misread it as reflux. Yes, reflux, things like that. But once they get a cut or something on their foot and it's not healing and they have bleeding in their socks and shoes, the foot starts to smell because that non-healing wound or sore is infected, and their foot starts to swell and they can't put any pressure on it, then they'll finally give and come to the hospital. Okay? So just understand that when we're talking again about arterial disease, the issue is ischemia. Okay? Okay, now the way ischemia works and trying to figure out where the culprit is, where is the blockage, we kind of lean into what are their symptoms. Because wherever they're hurting, the blockage is going to be north of that. For instance, if a patient is complaining about cramps in their hips or in their buttock area, then what's above that? So the vessels that feed those areas are going to be your common iliacs right here, and that's going to bifurcate into your internal iliacs, which are going to feed your reproductive organs and the buttock area, and then you have your external, which will feed the hip. So the patient's like, whenever I walk, I get these bad cramps in my butt or my hip, and I'll rest, I'll sit for a little while, and then they'll go away. Well, that's going to lead the doctor to think, okay, they probably have a blockage somewhere in either their distal abdominal aorta or the iliac region. Okay? Because if the vessel is blocked in the common iliacs, and especially if it's like one side versus another, like they're having cramping and pain in their right buttock or their right hip, then it's probably a right common iliac issue. If it's on the left, it's probably a left common iliac issue. Because right above that area, if the common iliac is blocked, that means all the vessels distal to that are going to have decreased blood flow. So the tissues that fills is receiving less blood flow. So the problem has to be north of where the symptoms are. I hope that makes sense. So if the patient is having left thigh issues or left calf issues, then we want to look in the external iliac artery. We want to look at the femoral arteries. We want to look at the what's not listed here is the superficial femoral artery, which is what arises after the femoral artery. And then after that, you're going to have the profunda, which is over here, which will kind of help feed the side of the calf. And then behind the knee, you have the popliteal artery, and we start getting to your lower extremities, okay, your lower leg arteries. But if they're having thigh pain, calf pain, then it's probably coming from the femoral or the superficial femoral artery. If they're having ankle, calf, foot issues, then it's probably something popliteal down, okay? So remember, wherever the pain is, the blockage is going to be just north of that area. So we have to think what vessel feeds this area and what's right above that area. And that's probably where your blockage is going to be. Any questions here? Too far. Okay, so outside of symptoms and the physical assessment and checking distal pulses, some other tools of assessment. You have your angiography. Of course, we come in, a patient comes in, we get vascular access, we get an artery or vein, and we take some pictures, right? If the patient is complaining of the ischemic symptoms, then of course we're going to look at the arterial side. So we're going to get an arterial access, usually right or left femoral. That's where we're going to start. Outside of that, then there's the ABI measurements. Okay, ABI is ankle brachial index. Okay, and we're going to talk about those testing a little bit more. But basically, we're trying to see if there's a difference or a gradient between the blood pressure in their arm and the blood pressure in their leg. Because the pressure should be pretty close to the same or pretty close to equal in both spots. But in the presence of peripheral arterial disease, there's going to be a difference. There's going to be a gradient or a mismatch there. And then there's the tibial brachial index, which is another version of the ABI. Okay. But all of these outside the angiography, all these things can be done in the office. And all of these things are usually done before they get sent here for an angiography. So we're talking about pulse assessment. Usually, again, in the cath lab, our big things, if we're doing a femoral stick or a radial stick, we're going to check your dorsalis pedis, your DPs, which is on top of your foot, and your posterior tibials, which is on the inside of your ankles, kind of behind the ankle bowl. I encourage you to check your pulses. So one, you know where they are. So when you're assessing a patient's pulses, you know where to feel, and that you can see if your pulses feel strong or weak, or you can't find them, and if you have any of those symptoms, and possibly talk to your physician about it. But it's always good to find these pulses on yourself, so when you have a patient, you'll know where to start your search for the pulses. Another place is the popliteal. Now, I'm not sure how often you guys are checking popliteal arteries or popliteal pulses. I know for me in the cath lab, usually the only time we would check a popliteal is if we're going to get access in a popliteal. And in order to get access, the patient has to be prone. They need to be laying face down on the bed, on the table, for us to get access to a popliteal artery or vein. And feel for that as well. So I want you to check these three pulses and see if you can find them and see what they feel like. So for your ABI, your ankle brachial index testing. So here we are using blood pressure cuffs and ultrasound devices. Okay. So what you'll see is here on the arm, you're going to use an ultrasound probe to find the pulse in the arm, the brachial artery, which is usually if you open your arm and palm up and you look for the bend in your elbow, your brachial pulse is going to be medial. Okay, so medial, of course, is being closest to your torso. But that's where you're going to find your brachial pulse. And hopefully, if you've ever had to do a blood pressure on somebody, and you're putting the cup on and that little arrow that says artery, hopefully you're placing that towards your brachial artery and not just the center of the antecubital area. Okay, so they're going to use the ultrasound probe to listen for the blood flow in that brachial artery. Okay, the blood pressure cuff is placed above that, and they're basically going to inflate the blood pressure cuff until they can find the systolic blood pressure. Don't know how long it's been since you have performed a blood pressure check, but wrap the cuff around the arm, make sure it's tight, not like restricted to where you're cutting off blood flow, but tight enough to where it's not going to move and it's in a stationary position. And you usually inflate the cuff to at least 20 to 40 over the patient's normal blood pressure. But you inflate it over and then you start to release the air until you hear the pulse. So when you're taking the blood pressure, if you're doing the old school with the sphygmomanometer and the stethoscope, then when you hear your first beat, that first sign of a pulse, that's usually your systolic blood pressure. So as you're releasing the pressure, and with the Doppler probe, you hear your first pulse, your first beat, that's your systolic blood pressure. And you want to measure that. Okay. Now the same situation is performed on the ankle. You have a cuff that's on an ankle, usually the same side. So the cuff is on, and you have an ultrasound probe on the PT or the DP. Okay. And so you do the same thing. You find your systolic and you measure it and you document it. And what you find here is you take the highest ankle pressure and you divide that over the highest arm pressure for the right and the same thing for the left. And what they're looking for is the ratio. So here's your scale. So anything less than 1.3, so 0.9 to 1.3 is normal, okay? 0.4 to 0.9, mild to moderate, they're going to start watching and observing it. And it's going to become a thing every time they go to the doctor. They want to check it and make sure. 0.4 and lower, they were looking at severe peripheral arterial disease. But this again is not usually performed in the cath lab. It's usually performed in the doctor's office or in a clinic somewhere. We'll get this data in the patient's records when they come to us. Okay. So here, this is a tibiobrachial index. So we have little bitty blood pressure cuffs on the big toe. So same thing's going to happen, but we're measuring pressure in the toe as opposed to the ankle. Duplex, they're going to measure the ultrasound. They're going to look at the pressures and the sound using the probes to get more information on how the blood flow is in the lower extremities. Duplex ultrasounds, I'm not for sure, but last time I was working in the hospital full time, They didn't do a lot of duplex studies. They do a lot of duplex studies for like the carotid arteries, looking for blockages there, and for arterial disease in the carotids. But in the periphery, a lot of the patients I had, they either had TBIs or ABIs. Alright, now let's talk about imaging. There are a couple of different imaging tools we have to assess peripheral vascular disease or peripheral arterial disease. And we have MRIs or MRAs, which is the magnetic resonance angiography. DSA, this is what we do in the cath lab, which is digital subtraction angiography. And then you have CTA, okay? When you see an A at the end and not an I, then you know there's contrast involved and we're doing angiography. It's just our imaging tool is going to be different. It's either going to be MR, angiography, or digital subtraction, or CT. Okay. Now, what you see here are a bunch of images kind of stacked up together. I'm going to focus on DSA because that's what we do. Okay? So, when we're doing DSA, the whole subtraction part is that we are editing out the bony parts, the bony pieces. So all we see is the soft tissue. Okay? So notice you kind of see the bones in the images, but they're not as in the way and pronounced and kind of laying on over the vasculature, kind of interfering with what we see. So the way digital subtraction angiography works is we're going to take a series of images at the same time. There's going to be your traditional angiography image, and then you're going to have your subtraction image. And that subtraction image is going to remove the bones and really overlay this soft tissue, the angiography. When you're doing DSA, you cannot move the table, you cannot move the C-arm while you're taking your images. Because what you're going to do, remember we're taking two images at the same time, is you're going to cause one of those images to move. When the image that's taking the bone out is I don't want to say it's stable, but it's stationary. It's not moving. So anytime you move the table of the C-arm while you're taking a DSA, you're going to get a blurred, distorted image, and you're not going to get what you need. You just waste the contrast. Another thing about DSA is that it takes very little contrast because all we're looking at is the vasculature. So we can use low ionic contrast, we can use low dose of contrast and still get great images because we're kind of eliminating all that other stuff that we don't want to see. So usually you'll start in the either the abdominal aorta if you want to look at the kidneys. If you don't care about what's happening around the kidneys, then you can do lower abdominal aorta first. And if you look at this one, you see our lower abdominal aorta. There's like a little aneurysm right there. And then that's going to bifurcate into the common iliacs right here. And when you have your first branch off of the common iliacs, those are your internals because it's going on the inside. Okay? And distal to that bifurcation is the external. That's going to go down into the legs. So we usually take this one first and then start getting the common femorals and the external iliacs. Next, you're going to get your superficial femoral arteries and profundas. All these little branches, they're great to see, but we really don't, I don't want to say we don't pay attention to those, but we really don't dictate on those. The doctors really won't dictate on those side branches. We're more concerned with the main branches. And if you notice here, so this vessel right here that goes all the way down the thigh, this is the superficial femoral artery, or the SFA. You notice here, the SFA on the right is severely diseased. It's severely diseased. And then you see some collateral branches that kind of come off of where it occludes. So it occludes probably around here, and all of these right here are just collaterals that are attaching right above the knee. So on the distal SFA, we have reconstitution of the SFA. And when you're working with peripheral vascular doctors or vascular doctors, and they're calling off what they're seeing, they're dictating during the procedure, they're going to use terminology like reconstitution. And when they say reconstitution, if they have an occlusion, where does it pick back up? Where are the starting points and end points of the collateral circulation? So when I say things that reconstitutes distally above the knee, that means that we now have vascular filling at the distal part of the SFA. This is what we have here. And you see we have pretty good perfusion here behind the knee. You see your little knee bones right there. And then it will trifurcate into your lower extremity vessels. Your perineal, posterior tibial, and your anterior tibial will be down here in your lower leg. Okay. So we're going to go over that again. I know it was a lot. So let's say we find a blockage. This blockage right here. We've got a mid-right SFA blockage that we want to fix. Okay. And we need to start getting our tools and start, strategizing on how we're going to fix it. So just like we do in the heart, if we're going to put something in the body, if we're going to put in a stent, a balloon, or something like that, we need to anticoagulate our blood so we don't get any unwanted clots to block up or hinder what we have to do. So it's going to be Angiomax or heparin. It's typically what's used. If we haven't already got access, let's say we're initially starting it, a lot of the vascular doctors like micropunctures. I know at Baylor, before we really got into doing vascular work, our doctors really didn't use, our cardiologists didn't use micropunctures. They used the standard access needle and sheath. No one ever mumbled a word about micropuncture kits. And it wasn't until the vascular guys came up and they were like, oh, we need a micropuncture. And because the peripheral vascular world, that's their thing. So they are more in tune on using tools like micropuncture and how it can help when you're dealing with a patient with known peripheral vascular disease. You know that getting femoral arterial access can be problematic, which is going to result in multiple sticks. And maybe even you may have to abort getting right common femoral access because the disease is so bad on that side that you have to go to the left side. And if you're using your standard access needle and you're making those larger holes and you're having the hole pressure and it's making the procedure go longer, you're increasing your risk of bleeding, pseudoaneurysm, and all that other stuff using the traditional access needle to get access on a patient with known bad peripheral vascular disease. So micropuncture is preferred, and depending on what they're going to fix and the direction they're going to go, the access site will either be retrograde or antegrade. Now, in the world of peripheral vascular disease, this is the first time that we've ever had to think about retrograde or antegrade approach, because in the world of CAS, treating the heart, everything is retrograde because we're going up the torso to the heart. There's never a situation or condition where we have to go antegrade. Okay? So if you look over here, retrograde is our traditional access. We're going in with the sheath pointing towards the torso, going towards the chest. Okay? And this is useful and beneficial if you are going to go contralateral. Contralateral access, let's say for instance the patient has a blockage over here on the left side. Okay, they have a left common iliac or left external iliac blockage right here. So the patient or the doctor can get access on the right side, retrograde access, and our equipment can go up and over the iliac arch over to the left side. That's contralateral. You're going over to the other side. Okay. Now, depending on where the blockage is in that external iliac, they may be able to go retrograde on the left side. But considering how long your sheath is, which is usually 10 to 12 centimeters long, you may actually want to put that sheath inside of the blockage. And so going retrograde on the same side is probably not the best idea. So the better idea would be for you to go retrograde, contralateral to the other side. Okay. Now, if the patient has any type of left side disease, left iliac, left SFA, down to the foot and the lower extremities, contralateral is great. Okay, it's fine. It's commonly used. Something else they may want to do is go antegrade, ipsilateral on the same side. So instead of having the sheath go in and kind of face up towards the torso, it's going to be kind of positioned downward towards the foot. Okay. Now, what that means for you as a scrub tech, it changes the way you drape your patient. Because if you're going antegrade down the leg, if you're going ipsilateral on the same side, that means all of your wires or catheters are going to be laying up on the torso. And depending on how long your equipment is, and you have to lay it out straight, and you have bulky devices, you may be having your equipment laid high up on the upper chest. You may have to cover the patient's head and kind of have your table up towards the head of the patient as opposed to on the side or towards the foot. All of your equipment may be up on the torso and the head. Okay, so it's always good to know what is our vascular approach before you start to set your table and drape your patient. So you will know how to, if you need to drop an extra drape to cover the patient's upper torso and head. Do you need to add an extender towards the head? Do you need to put a Mayo stand or one of those little trays over the patient's head to one, keep the drape off of the patient's face and also give you a place to place your equipment without putting them on the patient's upper chest, neck, or head. All that stuff has got to be pre-planned. Okay? So outside of this retrograde and antegrade femoral sticks, you do have an option for a popliteal stick. And a popliteal stick can be retrograde. It can be antegrade, but it's more complicated because the popliteal is very close to this trifurcation right here. And depending on what you want to fix, you don't want to get stuck into a posterior tib or a perineal or a vessel that you have no intention on fixing. Okay? So something else they're doing, which isn't on here, is they're now getting dorsalis pedis access. They're sticking the top of the foot. Okay? Which again changes the way you drape your patient. If you're going popliteal, that changes the way you drape your patient, because your patient is going to be face down. So you have to position your patient in a way to where they will be comfortable laying face down for the whole procedure. Some places have little donuts where the patient's head can be placed in the donut. Some people take the patient's arms and kind of raise them above their head or on the back of their head, or some places where they're comfortable. Some places have armrest extenders where the patient can just kind of place their arms kind of facing bent, but kind of, I hate that I can't show you. Let me see if I can show you, because I can't put it in words. If my camera's gonna work. But basically, put the arms out to your side, laying kind of next to the patient. Instead, I can't make my video won't work. So, anyway, but you'll have to completely reposition your patient. So this is one of those things like, oh yeah, the doctor wants to do a lower extremity runoff. You need to know access. You need to know if there is any potential for fixing something and what equipment you need to have out. You need to know what size equipment to have, because in the peripheral world, you have diagnostic stuff that's 4, 5, 6 French. And depending on what they want to use, you may start off with 5 French stuff, you may start off with 6 French stuff. The lengths of all this equipment, they're all different. The wires that you can use are 035, 018, 014. It's very, very specific, so you need to get with your preceptor, You need to get with the doctor and kind of get a game plan as to what we're doing and what equipment is going to be needed. But here, I want you to kind of focus on the different access options, okay? And understand what retrograde and collateral, what it means, and what ipsilateral is, okay? And if we have access on the right, but we're going to fix the left SFA, then know the preferred approach is going to be a retrograde contralateral, okay? Antegrade is great, but it can make things difficult depending on where the blockage is on the SFA. Now, if the patient has bad peripheral vascular disease on the right, but we need to fix something on the left, then we can go ipsilateral antegrade to get to what we need to get to on this side. Okay? That's why it's important to know what are we treating, where's the blockage, and how do you want to get in there. Make sure you have that conversation with your doc. So, in the world of cardiology and billing, a lot of our billing and documentation is done in like packages. So if we're doing a diagnostic right heart cath or a diagnostic left heart cath possible intervention, we don't charge per image we take. Say we have a left heart cath, coronary angiography, it's one package, one price, one cost, one bill to the patient. If we're going to do an intervention, okay, here again, we are going to charge by the vessel. So if you put 1 cent in the vessel, it's one charge. If you put 5 cents in the vessel, you're still only able to charge and get reimbursed for 1 cent. Okay? Peripheral vascular is completely different. Peripheral vascular can charge for the placement of the catheter. They can charge for the angiography of the vessel that they're in. Every time they move that catheter and reposition it in a different part of the vessel, they can charge for it. So that's kind of why a lot of cardiologists are doing peripheral vascular cases, because it pays better. It pays a lot better. So I say that to kind of get us into the different types of angiography. So when we're doing different types, it's either going to be a non-selective angiography or selective. Okay. Usually when we're doing a lower extremity, abdominal angio, whatever, it's usually going to start with a non-selective angiogram. Remember back in the summer we were talking about selective versus non-selective catheters, or flush catheters versus selective catheters? Well, these flush catheters or non-selective catheters are going to be used for these non-selective angiograms, these shots. So that'll be a pigtail, or a sauce omni, or omni flush, things like that. And I think there's some slides coming up that goes into the different catheters. But it's going to sit into a large vessel, like the aorta, and we're going to take a big general picture. And this big general picture, or this non-selective image, this non-selective angiogram, is going to show us where all of these different bifurcating vessels are coming off of. So here, you just kind of see the catheter here on the right side going up the vasculature. And if it went up a little bit higher, you can probably see a pigtail right here in the lower abdominal angio. And what this is doing is it's showing us exactly where that common iliac bifurcation occurs. It's showing us where that internal iliac bifurcation happens. And it's showing us the external iliac. Now, if we were to take this a little bit higher and do an abdominal aortogram, we will see where the kidneys come off. We will see the origins of the renal arteries. We will see where the mesenteric arteries originate. Mesenterics feature intestines. Okay? And you usually have a superior and an inferior mesenteric. And if the patient comes in with like abdominal cramping pain, unexplained weight loss, and pain and cramping after meals, then we need to focus and hone in on the mesenteric to see if we have lack of blood flow to the intestines, to that area. And so you will first start out by doing a non-selective angiogram in the aorta, be it in the mid, the distal, Wherever it is you're looking at, you always need to start with a non-selective shot. Even if you're looking down at the legs, you need to start with a non-selective shot. If anything, to see where this common iliac bifurcation is. Because if you're going to go contralateral, if you're going to access the right and go contralateral to fix something on the left, your equipment is going to come up through this and it has to hook this arch right here. Okay? And in order to do that without giving a whole bunch of contrast, you at least need to have a landmark. The cool thing about DSA is, I know we call it in the cath lab roadmap a lot where we just kind of put up a reference image, but in the peripheral vascular world, we can take this image and kind of overlay it onto a live fluoro. So instead of giving constant puffs to figure out where we are, we can create a roadmap, put this image over our live fluoro, and just follow the vasculature without giving any additional contrast. So again, if you're looking at the torso, you need an abdominal aortogram. If we're looking at the lower extremities, we need a distal abdominal aortogram so we can find this, so we know where to put our equipment. Okay. Any questions on non-selectives? Outside of your distal abdominal AO and your your mid-abdominal aorta, everything else is going to be selective. Once you get your catheter kind of hooked over this common iliac arch, you're now selective. You move it down to your external iliac, you're selective. So they're gonna charge for a placement here, and everywhere else they go is another charge. So make sure you know and you're familiar with this anatomy. At the end of your distal abdominal aorta, common iliacs, the first bifurcations, okay? Right common iliac, left common iliac. This is the iliac, common iliac arch. And you have your first bifurcation when the internal iliacs bifurcate from the common, okay? They're going to go inside. That's why they're called internals, because they feed the reproductive. Distal to that internal iliac artery is going to be your external. So I'll give you a picture, or ask you to label something on the exam, know where these different vessels come off. Okay? Now, when we start getting into selective angiograms, we're taking a catheter and we are selecting a specific artery for imaging. So here we have a right renal artery, and we're doing an angiogram and we're seeing the vasculature of the right kidney. So when the catheter is placed in there, that's one charge. When they take a picture, it's another charge. Here are some flush and selective catheters. Anytime, this one with the side hose, this is an Omni flush, and this is a SAS Omni. Whenever you see side holes and something like this, you know it's a flush catheter. You know it's a non-selective catheter. This SAS Omni can be used as a non-selective, but it also can be used as selective. This one right here, and even this one, can be used to go up and over the iliacs and select out this right common iliac or the left common iliac, depending on where your vascular access is. This one right here is purely selective. Okay, you can't take a large bolus angiogram with this one. You can't. So this is a selective catheter. So if I show you some pictures, I'll show you this one, and I'll ask you, hey, which one is flush and which one is selective. You gotta be able to tell me the two. Tell me which is which. Peripheral wire diagnostic catheters. Usually the diagnostic catheters are 035, because usually when you get into 018, you usually have some type of interventional device that you're using that requires an 018 wire. All of your diagnostic catheters are going to be 035. Now, the difference between these wires and that J wire that we use in the cath lab is that they're going to vary on the, not flexibility, but the stiffness of the body of the wire and the tip of the wire are going to vary. Usually a lot of these wires come straight and you have to form them, with the exception of the glide wire. Okay? But this Amplatz and this Benson, and there are others that are going to come straight. So if the doctors want to put a curve on them, they'll have to curve them themselves. Generally, the workhorse wires for the peripheral vascular world are going to be a Benson. It's going to be a woolly wire. Um, and there's another one. I can't remember it. Has anybody in here that's done peripheral vascular, have you ever used anything outside of a Benson or a woolly for your diagnostic portion? Anybody?
They have something. It just has a weird name, um, which I tried to pick, but I know what you're talking about.
Okay. But there's others out there, but I know Benson is the most commonly used workhorse peripheral vascular wire because it does have that floppy tip. Um, the body is supportive, but it's not stiff. Comparing that to the Amplat Super Stiff, the body or shaft of the wire is extremely stiff. It's almost like it's very stiff. If you are trying to rewrap your Amplat's wire, if you're not careful, it's going to unwrap and spring off your table. The distal end of that Amplat's wire is extremely stiff and aggressive, and it's usually painted a different color to make sure that you don't put that inside of the catheter to go inside the vasculature, because it will damage the vasculature. It will perforate or dissect the vessel if the bad end goes in. The glide wire advantage. The glide wire is a 035 wire that has a hydrophilic coating on it. Okay, so when you get it wet, it's super slippery and slick, and you may have to either use a dry gauze or something else to help you get control of that wire because of that hydrophilic coating. So you need to be very, very mindful of how to handle your glide wire. The glide wire advantage is a traditional glide wire for like the first, I don't know, 10 centimeters or so. And then everything after that is not hydrophilic coated. So it's regular wire, but it's a very stiff body wire. So like handling the Amplats, you have to be very, very careful and make sure you secure it when it's outside of the body. You want that to stay in a wet environment. So if it's not in the body, either put it in your equipment bucket that has this heparinized saline in it, or keep saline flushed in the wire tubing so it stays wet, because if it gets dry, it becomes sticky and difficult to use. Also, when it comes out of the body and it's covered in blood, be sure to wipe it down really, really good, because you don't want dry blood on a hydrophilic wire. Bad business. Also, right here, you see, do not use with any metal entry needles. So let's say you're trying to get vascular access on a patient with bad peripheral vascular disease, peripheral arterial disease, and the doctor is getting access to the artery and we're getting blood return, but they can't advance the wire through the needle. Okay. Now, once you get the sheath in, this is a great wire for navigating, heavily diseased areas and tortuous areas, because it's slippery. It'll kind of deflect and move throughout the vasculature. That's great. But you don't ever want to use this through a needle to try and get a wire advance through the needle, because what will happen is that hydrophilic coating that's on the wire will get shaved off on the needle. And then you'll have that hydrophilic coating circulating through the bloodstream, and that could be very, very bad for the patient. Okay? So always remember with this one, never send it through the wire, never send it through the needle. Okay? Only through the sheath or through a catheter. Never through a needle. But I wanted you to see these three because these are the three most commonly used ones. The Benson is a workhorse. I always use it in the beginning. Glide wire helps when we can't advance the catheter through a heavily diseased or tortuous area. And Amplat Super Stiff is used a lot when we're going contralaterally over the common iliac arch, and we need to provide support for our equipment going over that arch so it doesn't bulge out of that iliac arch and back up into the aorta. We want it to stay there and make sure our equipment gets up and over. The Amplat Super Stiff wire is really good about that. So make sure you know the purposes of these these three wires. So iliac intervention. Couple of different ways to approach it. If you have single iliac vessel disease or bilateral iliac disease. If you just have disease on one side, then of course you would go contralateral or you would go ipsilateral and fix that one area. You can balloon it, you can stent it, you can use atherectomy, you can use all the things, okay? Just know if you're doing iliac intervention, you can go from either approach, contralateral or ipsilateral, okay? But if you're going contralateral, then you have to have a very supportive delivery system to deliver your equipment so that this doesn't, you see how it's kind of bending right here? If you don't have enough support, it will push up into that distal aorta, and then you'll have a mess. Your equipment's not going to stay, and it'll be a whole 30 plus minutes added to your procedure. Now, if you have bilateral common iliac disease, then what they'll usually do is a kissing balloon or a kissing stent deployment, kind of like what we do in bifurcations and coronaries. With the exception, you're going to have bilateral femoral access. You're going to need something in the right femoral and in the left femoral. And then once you do that, you're going to need 2 sheets, 2 wires, 2 inflation devices. You're going to need 2 of everything, because once you place your stent or balloon in position, you're going to deploy them at the same time. Everything is happening in unison. So your doctor's going to have an inflation device on a stent or a balloon, and you're going to have the other one. And when they say go up, you go up at the same time, at the same speed, to the same atmospheric pressure. And when you come down and deflate the balloons at the same time. Okay? These usually give you great results. The bifurcation, the kissing iliac treatment technique. Just know those are some options. So understand your approaches for approaching and treating iliac disease, and know what's happening here in this image, and know what equipment you will need to perform this. You're going to need 2 of everything. Now, something I didn't mention is in peripheral vascular disease, generally they don't use a manifold. Vascular doctors really have no interest in arterial waveforms. They just don't. We're used to it. We want to see, we care about dampening, but for the most part, they don't use transducers and manifolds. Everything is done through single injection syringes. Okay? Which for you, as technologists making the table, when you're labeling your syringes, you make sure you label some contrast syringes. Make sure you label your contrast cup. Okay? Make sure you keep count of all the contrast that enters the patient's body. Because at the end of the case, they're going to need an exact contrast count on what was delivered to the patient. So if you got to take your sterile marker and write it down, you got to write it down. But generally they'll give you like 50 cc's of contrast on the table, and whatever it is you have left that you didn't put in your inflation device, then you can say that's what you gave to the patient. And that's what gets documented. Because contrast, again, is charged per cc to the patient. It's all about charging. Any questions on this iliac intervention? Alright, moving on. So, common femoral artery intervention. Okay. So, generally, common femoral arteries, we don't address in the cath lab. We don't address endovascularly unless it's something that we messed up that needs to be fixed now. Because what happens in the femoral area is that's a hinge point. When you sit, when you lift your legs, this area of the vasculature gets compressed. It bends. You know, there's torsion there. And for you to put in a stent, especially a stainless steel, platinum, whatever, anything that's not nitinol, will get kinked and cause an issue there. Also, this is an entry point for a lot of procedures. So if you put a stent there, you can no longer get access to this area. So if we do mess up something, let's say there is a perforation or a dissection, we'll treat it with a long balloon inflation, but we're not implanting anything in this area because it's a flexion point. If there's something there that can't be fixed with a prolonged balloon inflation, if there is blockage there that needs to be treated, it won't be treated by a stent. Okay. What's going to happen is the patient is going to go to have surgery and have an endarterectomy. They're going to have that vessel cut open and they're going to have that plaque excised from the artery. Okay. But we're not going to put metal in common femoral arteries. Make sure you familiarize yourself with this image. You have your external iliac artery, internal or inferior epigastric. So internal's up here. This bifurcation is closer to the pelvic bone, closest to the femoral artery or the femoral head is going to be your inferior epigastric. This, remember, if you remember correctly, proximal to this, sticking up here, puts you at risk of a retroperitoneal bleed. Remember, this is always that border. You want nothing sticking up above the inferior epigastric. So you have external iliac artery. Below the inferior epigastric, you have your femoral until it bifurcates into your superficial femoral artery and your profunda femoris or profunda femoral artery. This is your sheath. This is the sidearm for the sheath. It's not a vessel. Okay, we're taking an image in here. That's why the sheath is full of contrast. But identify this is the sheath. This is a common femoral. This is your external iliac. This is your superficial femoral, and this is your profunda. Okay? Any questions here? Alright, so let's talk about bypass. So just like in the heart, if the disease is too aggressive or if it's in a place that we can't fix with balloons or stents, we bypass them. They do bypassing on the periphery as well. I have a couple of different options depending on where the blockage is. Okay, so remember, you're always going to bypass from above the blockage, and you're going to bypass the blockage and attach below. So if we look at, this is like a whole graft bypass. We usually don't see those, but what we have here is this is a common iliac to femoral bypass. So they're bypassing this whole common iliac area. This is your graft. So the graft attaches above it and then below it in the SFA. Here they've done a fem bypass, so they've attached to one femoral artery, kind of crossed over that pelvic area and attached it to the other femoral. Here you have a, so this is aortobifem. That happens, but usually not that often. It depends on the placement of the disease, so I guess I can't say not that often. And this is a subclavian femoral with also a bifem. Now this one here is an aortobifemoral, so this is kind of this situation over here, but we have two grafts instead of this bifurcating Y graft. And then you have a femoral popliteal, which attaches at the femoral and attaches to the popliteal artery, which bypasses an SFA blockage. And then again, your fem, which is going to bypass an iliac blockage. Now, if I tell you aortobifem, say, hey, we got a patient coming down, we're going to do a lower extremity angiogram, but they have an aortobifem. What you should be thinking is, as a technologist, is, okay, what's my access point? Because never, ever, ever, at any point in time in the history of everdom do you stick a bypass graft. Never, ever, 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 ever do you stick a bypass graft. Because you can destroy the bypass graft. Okay? Because if you stick it, the only way to get hemostasis is to put pressure on it, and you don't want to compress a bypass graft because you can close it. So never, ever, 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 ever do you stick a bypass graft, a peripheral vascular bypass graft. So if your patient has aortobifem, you may be looking at a popliteal access point. Okay? Depending on where the blockage is. Now, if your patient has a single-sided femoral popliteal, well, you can get, depending on where that femoral attachment is, you can probably still do the common femoral, or the other side, go contralateral. Okay? If it's fem-fem, then hopefully if the fem-fem is low, if it's above the common femoral, then you can still get access up there. But at the end of the day, check with your doctor. Hey, what's our access point? I saw this patient has this type of peripheral vascular disease, a peripheral bypass. What's our access point? What do you want me to prep? Okay, and they'll let you know exactly where they want you to prep. Big thing is, do not stick a bypass graft, a peripheral vascular bypass graft, ever. AAA repair. So AAA repair is usually something we do in conjunction with an OR team or with a vascular team down in the OR. And AAA, abdominal aortic abdominal aneurysm, abdominal aortic aneurysm, they're going to go in with a graft, a stent graft, and place it inside of the aorta, kind of isolating or blocking out that aneurysmal segment, giving the blood flow a safe patent pathway to flow. Because we know the issue with aneurysms is that this is a weakened, dilated area of tissue, and it's prone to rupture. And with aortic rupture, there's not a whole lot of chance of survival if there's an aortic rupture. Okay. So when these are done, it's a lot of pre-work done before. There's CT images that are taken, MRI images that are taken, angio images that are taken, lots of measurements are taken. The endograph rep is there helping with measurements and finding the appropriate device. Sometimes they have to have some endographs specially made based upon the measurements they collected for that patient. A lot of times it's not a, access-wise, it's not a stick. Sometimes it's a cut down, a vascular cut down. So that's why it happens in the OR. And also in the case that something goes wrong, they can go open and surgically repair the aneurysm area. But these are some images. Here's the first diagnostic image. This is your non-selective shot in the mid-abdominal aorta. They want to identify where the renal arteries come off, the starting and the ending of the aneurysm. They want to see if the aneurysm is so large that it's impacting the renal arteries or if it's impacting the iliac arteries. Because if the aneurysm hinders or spreads into the iliac, then you have these additional pieces. Because if you look here, you can see it's like a whole piece with two legs. Sometimes they just have cuffs. So you may start with this piece right here or this piece right here, and you might have to add an extender cuff at the top. You may need to add an extender leg going into an iliac. But that's why they want to know exactly which areas of the aorta are impacted by the aneurysm. Lots of pictures taken. So this catheter right here, this is a marker pigtail, and there's like 10 millimeters distance between each marker. So they need to know the length, and then they can take their imaging system and calibrate this image and measure to see just how big the aneurysm is. But the most accurate number you're going to get for that is going to be down to CT or MRI. But they can still use this to measure the diameter of the aneurysm. But once they get everything in place, you take an image and you're going to see a lot of metalwork and you're going to see a lot of stenting, but it's all covered in some type of PTFE or graft material. But all it did is it created a new patent pathway in the aorta, and this aneurysmal tissue will eventually kind of wither down and not become an issue anymore. We no longer have to worry about the blood pressure and volume rupturing this area because now we have a completely enclosed graft material that is going to give us access inside of that, the vessels there. Any questions on this AAA repair? Okay. Renal intervention. We do a lot of these in the cath lab because, again, our patients are usually diabetic, have hypercholesterolemia, and usually have high blood pressure. And if a patient has high blood pressure and the doctor has tried multiple different types of antihypertensives, diet, exercise, lifestyle change, different types of antihypertensive medications and therapies, and the patient is non-responsive, then what they'll usually do is take a picture of the renal arteries. And what they may find is that there's a blockage in the renal arteries. And so they'll go in, they'll take a non-selective shot here in the aorta so we can identify where those renal arteries originate off of the aorta, and then do some selective shots. So here in this angio, you can see before we bifurcate into our upper and lower renal poles, there's a blockage there. Okay? So taking our first set of angio, there's two different wires. And what they've done is, if you look closely, you can see a stent that was deployed here in that upper pole, that proximal upper pole of the renal artery. And then your pulse image shows that it's now open. So if they find a blockage, treat the blockage, and the blood pressure goes down, it kind of returns to something closer to normal, then we know that was hypertension secondary to renal artery stenosis. And the patient can probably come off of all, if not a lot, of those medications, because we fixed the issue that was causing the hypertension. But renal anatomy wise, usually going to have two different poles. You're going to have a proximal renal artery, and it's going to bifurcate into an upper pole, which is going to be the upper half of the renal of the kidney, a lower pole, which is going to be the bottom half, or the renal artery can have separate ostia. The upper pole can have its own ostium, and the lower pole can have its own ostium. So when you're taking your non-selective shot, you can see if there's one ostium or if there's two, which is another reason why that non-selective shot is so helpful. With the renal artery angiogram, like anything else, you're going to need a guide catheter, you're going to need a wire, and whatever interventional tool you're going to use, which is usually just a balloon or a stent if you're in the renal artery. Because usually that plaque is soft, fatty plaque, and not anything weird like clot or calcification. So moving up to the upper extremities, we have a subclavian or an innominate artery intervention. So when we're doing subclavian or upper extremity work, you have the option of getting femoral artery access or radial, depending on the comfortability of your physician. Okay. You're going to use the same tools. Of course, you're going to do a non-selective shot using some type of pigtail or flush catheter, and then taking a selective catheter and getting closer images. So again, balloon stents, not a whole lot of difference in treating an upper extremity than a lower extremity. Now, carotid interventions. Carotid interventions are different. Because it's feeding the brain, we have to take very specific precautions. One, if we're going to treat it with a balloon or stent or something, then we need to have some type of embolic protection device in place. And because the blood flow is going towards the head, the embolic protection is going to be placed above whatever treatment device we're going to use. Generally, if there's carotid disease in the cath lab, we're only going to treat the external carotid, because that's what primarily feeds, the brain. The internal carotid will feed the face and, mostly the face tissues and muscles. And a lot of times I've seen physicians kind of let that go and treat medically, but the external they usually treat either with stent or balloon, or also motor surgery, and have a carotid endarterectomy where, like in the femoral artery, they'll cut the vessel and then excise the plaque in the vessel. When you're doing a carotid intervention, raise y'all's hands, y'all's virtual hands, if you've done a carotid intervention. Or a carotid angio, for that matter. Alright, So I just see one. So because you're in a carotid and you're, okay, two, you're kind of looking at the circulation that's going to the brain. Before the procedure, you have to perform a neural assessment, a neurological assessment. Their neurological assessment is going to involve checking how well the pupils dilate, with a light, seeing if the pupils react and dilate appropriately and equally on both sides. We want to make sure that the face is symmetrical, that having the patient smile. Does both sides of their mouth go up appropriately and equally? Have the patient stick their tongue out of their mouth and move it from side to side. Do they have function? And does that look appropriate? Asking the patient, if they know who they are, where they are, what the date is, and some other question to see if they're alert to person, place, and time. Checking the strength of their hands, so having the patients squeeze your fingers, with both hands at the same time. You want to get a gauge of what that strength feels like. Is it equal? Is it strong? Have them close their eyes and put their arms out in front of them to see if the arm's straight. But doing that full assessment before and after the procedure. Even if we didn't fix anything, we still need to do a neuro assessment after, because we've injected contrast, we put catheters up and down in the carotid, and we could have knocked something loose, we could have embolized air, we could have done something. So we need to make sure that we do that assessment at the beginning and end, whether we fix or not. Also, some cath labs utilize little squeaky toys, like a little doggy toy or a squeaky toy, and we'll put the squeaky toys in the patient's hands. So if we are working on the left carotid, we're going to put the little squeaky toy in the right hand, because the left side of the brain operates the right side and vice versa. If we're working on the right carotid, we want a squeaky toy in the left hand. So every time we do an injection, every time we put a wire or catheter in and out of the vessel, we want the patient to squeeze the toy. That lets us know that we haven't done any damage. Okay, they still have function of that affected side. What else do we do? Embolic protection, neural assessment before and after, and the squeaky toy. Yeah. So those are the big differences with carotid interventions and angios than the rest of the peripheral vascular stuff we do. Any questions on this? Okay. So here are some different catheters that can be used. Your question?
I have one question regarding the slide 15. Could you please repeat 15, that flush catheters? Could you please explain name one after the other, 3 catheters?
Okay, we're about to get into that right here. That's
Yes.
what this is. So the catheters is a couple of different catheters you can use. Pigtails are pretty universal. We have cardiac pigtails, we have peripheral vascular pigtails. So anytime you see a vessel with multiple side holes that has a curl like this, then it's a pigtail. So a sauce is a catheter that kind of looks like a unfurled pigtail, but it will have some side holes in it. Okay. Cobra is sort of kind of shaped like a cobra. That's where the name came from. Simmons 1, Simmons 2, Sim 1, Sim 2. Sim 2 was longer than the Sim 1. And then Bernstein and JB1, those are used a lot in accessing the great vessels to get us to the head and neck. So the pigtail is used a lot in the aorta. The aortic arch, the abdominal aorta, thoracic aorta, distal aorta. That's where the pigtail is going to be used. The sauce is going to be used a lot in the common iliac arch and pretty much nowhere else. going all the way back to this one. So this is the sauce. This is the sauce omni, the sauce, whatever. But this is used to usually to hook that. Oh, dang it, stop. This is usually used to hook that common iliac arch. Okay. This omni flush is a version of this. It's a shorter tip, plus it has the side holes for the whole flush feature. Now this one could be a Tempo Aqua, could be, which is kind of equivalent to a multi-purpose catheter that we would use in the coronaries. It's a very generic curve. It can be used for selecting out various different arteries, usually in the torso. So like kidney, a mesenteric, a splenic, something like that. But coming all the way back down here, these right here specifically used for cannulating the great vessels. So that's carotids, innominates, subclavians, vertebrals. That's what these are used for. Am I going to hold you to know these on the exam? No, I'm not. Because everybody uses something different. And unlike the coronary world, there's really outside of the pigtail, the sauce, the omniflush, or the sauce omniflush, there really aren't like staple catheters that everybody's going to use. If you're doing a left heart cath, everybody's going to use a pigtail JL4, JR4, or an FL4, FR4. But in the vascular world, it's heavily driven on peripheral vascular doctor preference. There's no discussion board. This is an old PowerPoint. But any questions on this that we've talked about? Okay. Any questions? Yes, sir, James.
Oh, well, because no one was talking, I have a question, but it's not on this, so maybe after.
Okay. Anybody else have a question regarding the lecture?
Could you please go back to the slide 16, those wires? Could you please name these 3 wires?
Well, the names are on the wires.
Okay.
It's on the packaging.
Okay.
The Benson, Glide Wire Advantage, and the Amplex Super Stiff.
Okay. Okay, ma'am. Thank you.
You're welcome. Any other questions pertaining to this stuff? Okay. I gotta change the date on your homework. And so today, hopefully all outstanding homework will be graded. That's my task for today. I'm not doing anything else but sitting here and doing homework all day. And you have all of your exam review stuff. And again, on Monday, we're going to have our review for 1340, 1350. I think I'm looking at the module, and I don't see where I have a little anatomy chart. So I'm going to put a vascular anatomy diagram up here that I want you guys to be familiar with. So that's going to be on the final exam. But outside of that, I don't have anything else for you guys. So we can end it here, and just remember to take that pre-test for your ACLS class tomorrow, because they're not going to let you in unless you have the printout showing that you passed the pre-test. And refer back to that email for any questions on the class, because I don't have access to it. It's not my class. I have no control. I don't have any of the materials. So refer to the email of the instructors. Email them with questions about the class. I'm not going to be able to help you with it. Yes, ma'am. Ms. Dominique. I don't hear you if you're talking. Dominic, you have a question? I can't hear you. Can you type it in the chat if you're talking? For everybody else, if you don't have any questions or anything, y'all can go ahead and go.
Yeah, I have a question, please.
Yeah, you hang around. Everybody else can go if you don't have a question. And I will see you guys next Monday. Have a happy Thanksgiving.
Thank you very much.
Thank you.
You're welcome.
Thank you, Richard.
Thank you.
You're welcome. Bye, y'all.